Welcome to the second installment in the KDIGO Webinar Series on genetics and CKD. This webinar will focus on genetic testing applications in glomerular diseases, a deep dive into FSGS and SRNS. Some housekeeping notes: today's webinar is being recorded. You can ask your questions early and often during the presentations. We'll have a brief Q&A period at the end. Just type in your questions in the chat interface and submit them, and questions that we don't have time for will be submitted to our expert presenters for individual follow-up. This KDIGO webinar series is supported by Natera. We'd like to thank them for their support. Our speakers today are Dr. Keisha Gibson, Clinical Associate Professor of Medicine and Pediatrics and Chief Pediatric Nephrologist at the University of North Carolina at Chapel Hill in the United States. Our first speaker today is Dr. Adrian Liew, Senior Consultant Nephrologist and Director of the Kidney and Transplant Practice at Mount Elizabeth Novena Hospital, Singapore. At this time, I'll turn it over to Dr. Liew. Go ahead.
All right, thank you. So I'd like to thank KDIGO for the opportunity to participate in this very important webinar. I'll be speaking on the applications of genetic testing in adults with focal segmental glomerular sclerosis, or FSGS. These are my disclosures. Now, FSGS is a descriptive term for a histopathological pattern of injury, and really that is all that it is. The characteristic feature is the presence of glomerular sclerosis in a segment, and hence the term segmental, of at least one glomerulus in the entire kidney biopsy specimen, and hence the term focal. However, confusion has arisen because when we started ascribing the term FSGS to a disease entity, we tried to standardize the nomenclature of FSGS in the upcoming KDIGO guideline update on glomerular diseases, and we had retained the term primary FSGS to refer to a condition due to a presumed but still unidentified circulating factor. Now, these patients often present with a sudden onset of nephrotic syndrome, and where immunosuppression continues to be a mainstay of treatment. Now, FSGS lesions due to an underlying genetic mutation is considered as a separate category because it has a very different treatment and prognostic approach. And this will be the focus of our talk today, and I will be reviewing some of the clinical application of genetic testing in adults with FSGS. Now, genetic FSGS are due to mutations to target proteins in the filtration barrier, affecting those of the podocytes, slit diaphragm, glomerular basement membrane, as well as the fenestrated endothelial layer. There have been more than 50 monogenic FSGS mutations identified so far, with predominantly an autosomal recessive mode of inheritance in children and an autosomal dominant model in adults. The true epidemiology of genetic FSGS in adults is unfortunately difficult to ascertain, as genetic testing is not widely available in many regions. Now, in a Canadian study analyzing the Toronto Glomerulonephritis Registry, the authors reviewed the results of whole exome sequencing of patients with FSGS and found genetic mutations in about 28% of patients with a family history and 8% in sporadic cases, giving an overall mutation diagnostic rate of about 11%. Now, genetic variants were also more likely in this study to be present in those who responded poorly to treatment, with the majority of mutations attributed to collagen disorders. The geographical distribution of genetic FSGS is dependent on several factors, including the population that's being studied. Now, as mentioned before, genetic testing is not widely available or performed in some regions and account for lower reported rates in these countries. Now, in regions where consanguinity are prevalent, the prevalence of genetic FSGS may be as high as 30% to close to 50%, depending on the reported studies, in contrast to low rates of less than 5% in outbred populations. Furthermore, the existence of founder mutation could also affect the prevalence rates. For example, in Europe, podocin or NPHS2 gene mutations are more common than in Asia due to different founder mutations in that region. Genetic form of FSGS are also less common with increasing age of onset of the disease, with high rates of mutations noted in the pediatric age group. An international study involving about 1,800 families noted causative mutations in about 11% of patients with onset of disease in the adolescent age group of 13 to 18 years age. And this is similar to what was reported in the analysis of the adult population from the Toronto GN Registry. But however, the actual prevalence in the adult age group is difficult to infer due to the paucity of large studies in this population. But we do think that it's probably around 10%. Now, the cost of genetic testing used to be significantly prohibitive, and it's time-consuming and complex, making it impractical to consider this test in routine clinical practice. But the development and availability of next generation sequencing technology, though, has made genetic diagnostic much more practical and clinically relevant. Using a technical platform of massive parallel sequencing with spatially separated and clonally amplified DNA templates, this sequencing technique has enabled a drastic increase in available sequence data at a faster pace with improved accuracy and at a significantly lower cost. Now, the next generation sequencing technique can identify disease-causing mutation in the entire genome, which is referred to as whole genome sequencing, or just the protein coding region, known as whole exome sequencing, or to a specific set of genes of interest, in this case, FSGS, using a targeted gene panel. Now, this table summarizes the advantages and issues of each of these three different approaches for gene analysis, in particular in patients with FSGS. Now, while whole genome sequencing is an unbiased approach for detecting genetic variation in both exons and introns, the inherent complexity of decoding this massive data set and the higher associated cost that will be incurred currently limits its clinical utility and probably is more useful in research settings. In whole exome sequencing, every exon of every protein coding gene is enriched by one or several capture methods and then sequenced by next generation sequencing and analyzed. And as a much more focused and economical approach compared to whole genome sequencing, whole exome sequencing is currently the more popular platform for discovery of rare disease-causing gene. Now, target gene panels are optimized for coverage of target sequences and consequently have higher read depth and accuracy compared to typical whole genome or whole exome sequencing outputs, and which improves the quality of the sequencing. The other advantage of employing gene panels for clinical use is the much reduced cost compared to the other two approaches. Now, however, target gene panels cannot review mutations in new genes not included within the panel, so the panels must be updated regularly. These panels are available commercially for FSGS and the nephrotic syndrome and are commonly used for genetic evaluation of patients with FSGS. Now, this is an example of a targeted gene panel for evaluation of FSGS from a publication in 2019. The authors used a set of panel genes for FSGS and nephrotic syndrome, and those genes that are involved in broad renal diseases. Now, despite improvement in technology for genetic testing, the cost and availability of genetic tests for FSGS are still considerable obstacles for prime-time use. And consequently, genetic testing is not widely employed, nor is there strong consensus for its routine use in all patients with FSGS. And therefore, a more tailored clinical approach will be more cost-effective and will provide greater diagnostic and therapeutic yield. The most common application of genetic testing in patients with FSGS will be in patients with resistant disease. So let me introduce our young patient. He's a 24-year-old Filipino gentleman with a not so uncommon clinical scenario of resistant FSGS. He presented with nephrotic syndrome and was diagnosed with primary FSGS at the age of 22. He was treated with high-dose corticosteroids therapy and unsurprisingly was developing intolerance and also had a poor clinical response and was therefore switched to a calcineurin inhibitor. He continued to respond poorly to treatment and was developing calcineurin inhibitor-associated nephrotoxicity, and conversion to other immunosuppressive agents were also unsuccessful. Now, so it is estimated that up to about 60% of patients with primary FSGS will respond to corticosteroid treatment, while resistance to immunosuppression is common in genetic forms of FSGS. Now, if you look at an extract of the summary table on the left, it is immediately apparent that resistance to immunosuppression is a common feature for many of the mutations. In fact, resistance to corticosteroid is a consistent finding in all forms of genetic FSGS. Now, for example, in the study from the Toronto GN registry, none of the patients with genetic mutation had ever achieved a complete remission, a finding that is consistent in other studies. There are certain mutations that, however, may respond to immunosuppression agents other than corticosteroids, mostly to calcineurin inhibitors, and these are listed here. And one of these mutations that I would like to focus on is the TRPC6 risk variant, because it occurs mainly in adult onset FSGS population. Now, TRPC6 is a non-selective cation channel with 6 transmembrane domains and found in the slit diaphragm. Mutations have been reported in not just familiar cases, but in sporadic forms of FSGS in the adult population. It is inherited in an autosomal dominant pattern with variable rate of progression to ESKD. Now, at least 5 mutations have been described, with 2 in clinically non-familiar cases. I would like to highlight that only about 3 variants are gain of function mutations that resulted in an increase in calcium current amplitudes across the membrane. Now, so TRPC6 is involved in the activation of the NFAT pathway through calcineurin, resulting in a direct proteinuric effect on podocytes, podocyte apoptosis, and eventual glomerular scarring. Therefore, intuitively, from a mechanistic point of view, calcineurin inhibitors could block this pathway and theoretically have a therapeutic effect in TRPC6-associated FSGS. Now, however, this has not been systematically evaluated, and only cases with, at best, partial response to calcineurin inhibitors have been reported. Moreover, not all TRPC6 pathogenic variants, as I mentioned before, are gain-of-functions mutations, and the molecular mechanisms are therefore still unclear. Nonetheless, for lack of better data, patients with a TRPC6 mutation could be considered for a trial of calcineurin inhibitor treatment, especially in the setting of corticosteroid resistance or intolerance. Otherwise, most of the mutations documented so far in adults with FSGS are resistant to immunosuppression, and genetic testing in patients with resistant disease, therefore, will have a much higher diagnostic yield. In addition, some of the genetic mutations have phenotypic characteristics beyond the kidneys, and genetic testing in patients with syndromic features may be beneficial, such as those with Charcot-Marie tooth or even the nail patella syndrome. Therefore, genetic testing may unearth mutations in adults with FSGS when there is poor response, at least definitely to corticosteroid therapy, and possibly to calcineurin inhibitor treatment, especially when patients are exhibiting intolerance or side effects to these therapeutic agents. And since genetic FSGS are resistant to immunosuppression, the discovery of these genetic variants may prompt a discussion on discontinuing further immunosuppression treatment. Now let's switch gears and discuss the role of genetic testing in adults with FSGS who are being evaluated for a kidney transplant. So going back to our patient, he did not respond to any form of immunosuppression and was developing opportunistic infections. He subsequently developed ESKD and was initiated on peritoneal dialysis. His older brother has come forward as a potential living kidney donor, and the family has two main concerns. Number one is, will the disease come back after the transplant? And number two, will the brother develop kidney problems after the transplantation? Now, if we examine the recurrence rate of primary FSGS, the condition that we said is due to a presumed circulating factor after transplantation, the recurrence rate can be as high as more than 50% in studies which employ a very strict criteria for defining primary FSGS. Now, in the most recent study involving centers from Europe, North and South Americas, the overall recurrence rate was about 32% for primary FSGS, with each continent hovering around 30-odd percentage points. The median time to recurrence was also relatively short at about 1.5 months, 1.5 months after transplantation. And this high recurrence rate for primary FSGS has clinical significance on transplant outcomes. The authors have gone on to demonstrate, as in other studies, that patients with recurrent primary FSGS has a much higher risk for graft loss compared to those whose disease did not recur. And patients with recurrent disease who did not achieve remission with treatment were also more likely to lose their allograft. Now, however, the situation is very different in genetic forms of FSGS after transplantation. It is widely accepted that kidney transplantation should be the best treatment option for patients with genetic forms of FSGS, as the rate of recurrence is significantly low, with several studies reporting over 0% recurrent disease. Now, the mutation in question is also important for predicting transplant outcomes. So, for example, in podocin mutations, the risk of recurrent disease is extremely low, as reported in this international study of about 83 patients. Now, none of the patients with homozygous or compound heterozygous NPHS2 mutations develop recurrent FSGS, compared to about 45% of patients without the mutations. Now, there have been only one reported case of recurrent FSGS in a patient with TRPC6 mutations. So the risk is still acceptably quite low. And of course, in evaluating a living related donor, it is important to determine the genetic risk of developing the similar FSGS condition after transplantation. Now, in line with providing good clinical care to kidney donors, the KDIGO 2017 guidelines suggested that donor candidates found to have a genetic kidney disease, in this case genetic FSGS, that can cause kidney failure should be excluded from donation. Therefore, genetic testing in the donor would not only provide information on the risk to the donor for kidney disease, but allow a more informed discussion on the appropriate choice of the kidney donor and whether disease donation should be considered instead. Now, in addition, some transplant centers had considered the use of preconditioning regimens such as plasmapheresis, LDL apheresis, or B-cell depleting agents to reduce the risk of recurrence of primary FSGS in the allograft. And therefore, the determination of a genetic cause would preclude the use of these procedures, which are often invasive, costly, and are of a higher clinical risk. Therefore, genetic testing may be considered in adults with FSGS who are being planned for kidney transplant, and also for their potential living related donors. The information will be useful to assess the risk of the recurrence in the allograft and graft survival, and provide guidance to the risk of the disease in the donor and choice of donor selection. And in centers where preconditioning regimens are used for patients with primary FSGS, these procedures could be avoided if a genetic variant has been detected. And finally, I would like to spend some time reviewing the effect of APOL1 disease variants in adult FSGS, as there have been a significant interest in this area in recent years. Now, the APOL1 gene is one of 6 members of the APO gene family on human chromosome 22. Now, 2 disease-causing APOL1 genetic variants have arose and observed in individuals with recent African ancestry, as they are also protective against African sleeping sickness caused by trypanosomes. Now, one risk variant called G1 contains 2 amino acid substitution near the APOL1C terminus, while the second variant G2 is a 2 amino acid deletion that occurs in the same functional domain of APOL1 as G1. Now, the non-risk APOL1 allele is referred to as G0, and the APOL1 risk alleles increases the risk of kidney disease following a mostly recessive mode of inheritance, where inheriting 2 risk alleles of APOL1 greatly increases the risk of kidney disease, while inheriting only 1 risk allele confers at most a small increase in the risk or else no increase in the risk depending on the clinical scenario. Now, there's observation that APOL1 risk alleles have been associated with an increased risk for the development of various kidney disease, in particular FSGS, HIV-associated nephropathy, and hypertension-associated ESKD. And these mainly occur in patients of recent African descent. Now, this has resulted in the term APOL1 nephropathy. Now, because 2 risk variants of the APOL1 gene confer significantly high odds ratio for these conditions, which were previously thought to represent just distinct clinical entities. There's some suggestions that these diseases are driven by similar or at least overlapping mechanism, and as such, it might be more useful to think of these diseases as part of an APOL1 nephropathy spectrum rather than as separate disease states in individuals with high-risk genotype. And if we look at FSGS specifically, patients with FSGS having the APOL1 risk alleles had a younger age of onset of the disease, with 70% presenting with the condition between 15 to 39 years of age. And in a recessive model, APOL1 risk variants conferred a 17-fold higher odds for the development of FSGS. Now, there are 2 observations that I would like to highlight with regards to the association of APOL1 risk alleles and FSGS. Now, in a study from the United States, the high-risk APOL1 genotype has a high penetrance and can be detected in about 75% of Black patients with FSGS. Now, in the absence of an APOL1-directed therapy and with a high rate of detection of this mutation in adults of recent African ancestry having FSGS disease, the clinical value of genetic testing for this particular genotype is therefore debatable. Secondly, while the genotype has high, it does not have complete penetrance, and it suggests that other factors, including environmental and social variables, may have contributory effect to the development of the disease. However, the biology of APOL1 risk variants in kidney transplantation brings strong argument for its clinical utility, for the clinical utility of genetic testing of APOL1 mutations in donor screening. Now, multiple studies have demonstrated that APOL1 high-risk donor kidneys fail at a higher rate than non-risk kidneys, while the recipient APOL1 genotype has not yet been shown to affect graft survival. Now, these observations suggest that kidney APOL1, rather than circulating APOL1, which is produced primarily by the liver, is actually the critical driving factor, is the critical factor that is driving the APOL1 kidney disease. And therefore, screening living-related donor for APOL1 genotype may be an attractive measure in improving allograft outcomes in recipients with APOL1-related FSGS. Now, this is currently being investigated in an ongoing multi-center study called Apollo, which aims to define APOL1 transplantation outcomes for both recipients and donors. And therefore, genetic testings for APOL1 risk variants may be considered in living-related donors or any donors with suggestion of recent African ancestry. However, the value of testing for APOL1 in Black individuals with FSGS and have no plans for kidney transplant is questionable, since there is a high rate of detection in this population and no therapeutic options directed against APOL1 is currently available. So to summarize, the clinical utilization of genetic testing in adults with FSGS is not straightforward. In the upcoming KDIGO Glomerular Disease Guideline update, we will suggest that there is no role in routine genetic testing in all adult patients presenting with FSGS. It should be considered in patients with nephrotic syndrome who fail to respond to initial therapy for primary FSGS. In those with an FSGS lesion on the kidney biopsy but do not have nephrotic syndrome, genetic testing may be considered in individuals where an underlying secondary cause could not be found. Now, the guideline will also provide some additional suggestions where genetic testing may have some clinical utility. Genetic testing should be considered in those where there is strong suggestion of a familial or syndromic disease, or when the clinical features are not compelling of a particular disease phenotype. Genetic testing may also be useful in the evaluation of donors and adults with FSGS preparing for kidney transplant. The use of genetic testing in prenatal diagnosis is less defined, but may be advocated in certain clinical scenarios. And with that, I thank you for your kind attention.
Thank you very much, Dr. Liew. Now I'll turn things over to Dr. Gibson. Go ahead.
So it is a pleasure to join all of you, my colleague Dr. Liew, and the KDIGO staff for this webinar today. Understanding the role of genetics in the care of the children we care for with difficult to treat nephrotic syndrome is becoming more and more important and relevant. I would like to submit these following disclosures. I have research supporting these entities, and I sit on the advisory board for these entities, but they will not be influencing this presentation today. My final disclosure is that I am not a geneticist, and so I am speaking to you today through the lens of a clinician who cares for a lot of children with steroid-resistant nephrotic syndrome, trying to make sense of this rapidly evolving field. I'd like to open this presentation with a case that may be all too familiar to my pediatric colleagues. Sarah is a 6-year-old child diagnosed with nephrotic syndrome after presenting with 4 weeks of periorbital edema that was treated as allergies. She was treated per KDIGO guidelines with oral prednisolone at 2 milligrams per kilogram per day, but at 4 weeks was noted to have no signs of remission. She was admitted at that point and given 3 days of IV Solu-Medrol, but continued to show no steroid response. Decision was made to pursue renal biopsy, and you'll note at that time that she had a fairly normal creatinine clearance. Her biopsy revealed 26 normal appearing glomeruli, but mild tubular interstitial fibrosis and tubular atrophy, all features that are very concerning for chronic progression of disease. So as the treating nephrologist, you now have a decision to make with this family. Do you begin treatment with a calcineurin inhibitor and RAS blockade? Do you opt to begin treatment with RAS blockade alone? Or do you consider pursuing genetic testing before any treatment decisions are made? So over the next 20 minutes, we're going to review some information and data that will hopefully help guide these decisions. In thinking about potential roles for genetic testing, clinicians may consider the impact on their treatment decisions either before steroid initiation, for example, in older adolescents with initial presentation of nephrotic syndrome, or after steroid resistance is established and decisions for further immunosuppressive treatments need to be made. Potential roles for genetic testing may lie in syndromic forms where we know there is a higher prevalence of Mendelian forms of podocytopathy, Families may be interested in pursuing genetic testing to understand the risk to future and current siblings. As you've heard eloquently from my colleague, Dr. Liew, there's a role for genetic testing as it pertains to kidney transplantation. We certainly understand that there are some podocyte-specific mutations that are associated with a negligible recurrence rates of disease post-transplant, like podocin. And pediatrics, children that have nephrin-induced mutations or congenital nephrotic syndrome, we recognize that there is a low recurrence risk of nephrotic syndrome post-transplant, but these children can develop anti-nephrin autoantibodies and have a clinical phenotype that's very similar to anti-glomerular basement disease. So there are implications there for how these children are monitored post-transplant. Decisions about entry and/or stratification in prospective clinical trials in the future is another area for potential roles of genetic tests. More than 50 monogenic causes of steroid-resistant nephrotic syndrome and FSGS have been identified. Mutation rates in pediatric patients with steroid-resistant nephrotic syndrome have been reported anywhere from 10 to 30% in various cohorts. In this particular study, genotype-phenotype correlations in a cohort of 291 Korean pediatric patients with steroid-resistant nephrotic syndrome were analyzed. The overall mutation detection rate in this cohort was quite high at 43.6%, so 127 of the 291 patients enrolled. WT1 was the most common causative gene, accounting for about a quarter of the mutations found, followed by coenzyme Q6. Now we're going to contrast this relatively ethnically homogeneous population with this population in North America with a more genetically mixed population. So these patients who were undergoing a clinically indicated biopsy for the first time, regardless of their response to immunosuppression, were enrolled in the Nephrotic Syndrome Study Network, or Neptune study. 20 known Mendelian nephrotic syndrome genes were interrogated across 311 patients, 95 of which were children. Of the 95 children included here, only 6.3% had a putative known Mendelian form of nephrotic syndrome. So really contrast this to the high prevalence of mutations noted in our previous Korean cohort. The PODINET registry includes children with steroid-resistant nephrotic syndrome across 31 countries in Europe. In this cohort, over 1,100 patients were enrolled, and podocyte-specific mutations were identified in almost a quarter of them. Almost half of these children achieved complete remission with intensified immunosuppression, but on closer look, among those with an identified mutation, only 13% achieved some transient remission status. So a much lower response rate here for children that had a known mutation. If you look at the graph on the right, you will note that these mutations certainly had a higher prevalence in those younger age range, and this will have some implications later when we discuss where are your high yield populations when you're considering genetic testing. It's understood that a common manifestation of children with steroid-resistant nephrotic syndrome is FSGS on biopsy. Due to a paucity of biomarkers, our phenotypic characterization of nephrotic syndrome diseases are largely dependent on histologic classifications. And with the common final pathway of many glomerular diseases ending with fibrotic changes that easily mimic FSGS, it's easy to see how dependence on biopsy findings may lead to incorrect diagnoses, or at least phenotypic characterizations that do not match genotype. One term gaining traction is phenocopy, which refers to a phenotypic trait or disease that resembles the trait expressed by a particular genotype, but in an individual who is not a carrier of that genotype. Now, this term, coined by Richard Goldsmith in 1935, originally referred to an environmentally induced non-hereditary phenotypic modification that resembles a similar phenotype produced by gene mutation. One example of this is in Drosophila melanogaster, where a variety of environmental factors like temperature, shock, or radiation produce abnormalities in these flies that resemble the abnormal phenotypes of known genetic mutations. We call these phenocopies. In this cohort of children in the United States, the following list of genetic mutations were found in children that actually carried a clinical diagnosis of FSGS. So here we see a long list of potential phenocopies of children that clinically on biopsy have FSGS, but genotypically fall into other classifications. Very recently, Groupman et al. Reported their experience with exome sequencing analysis in over 3,300 ethnically diverse adult patients. In fact, roughly a third of this cohort were of non-European descent, so a very ethnically mixed population again. Diagnostic variants were found in roughly 10% of these patients through exome sequencing. And as you can see in the chart on the left, about 30% of these mutations involve type 4 collagen defects and 31% polycystic kidney disease related genes, which is a remarkable finding in and of itself. However, if you focus on the figure on the right and focus here with the type 4 collagen disorders, you'll find that almost 62% of these individuals were either misclassified as having glomerular diseases like FSGS or carried no disease diagnosis at all. These results illustrate the potential for genetic findings to provide new clinical insight that may alter medical management or in some cases influence the choice of therapy. You're not going to inundate a patient with immunosuppressive therapies if you know they have a type 4 collagen mutation. So this raises the question of who should get genetic testing. Traditional high-yield populations for genetic testing include children less than age 1 at presentation, children that have syndromic features, and those that have a family history of steroid-resistant nephrotic syndrome. These data, however, extend the question of the utility of genetic testing for steroid-resistant nephrotic syndrome into early adulthood. In the last decade or so, advances in genetic analyses have led to the rise of a new generation of clinical molecular testing methods, which has really moved the field from traditional single gene analyses to now Sanger sequencing, which sequences short pieces of DNA, whole exome sequencing, whole genome analyses, and now targeted next generation sequencing, which can sequence large amounts of DNA in a cost-effective manner. The advantages of these broader testing methods have been embraced by many pediatric subspecialties and adult neurology, but we're seeing this reach extend into broader areas. Sanger sequencing is the oldest or original sequencing technology that we'll discuss. This is used for sequencing 1 or 2 specific genes or risk variants. While newer techniques are most often employed now, Sanger sequencing is still used for confirming findings from next generation sequencing that we'll speak about in a few minutes. Advantages of this modality include high analytical accuracy, the absence of the need for computational analyses because you're not dealing with large volumes of data, and the low cost associated with evaluating one specific region. Disadvantages include the inability to detect large structural variants. You're limited to a small section of DNA, and so this is not a technology that can rapidly scale up. It would literally take years to sequence a person's entire genome using this modality. Whole exome sequencing is useful for targeted sequencing of the all protein coding regions or exons of the genome. It is good for patients who remain undiagnosed after they've been analyzed via more targeted sequencing panels like next genome sequencing that we'll talk about. It's also useful for patients with unclear phenotypes and useful for the discovery of new genes. So the advantages here include its increased sensitivity for evaluating specific genes, specific diseases and phenotypes in the coding region compared to more targeted modalities. The identification of single nucleotide variants at loci that weren't considered at initial assessment can be assessed frequent reanalysis because you've generated all of this data. So you can go back and interrogate with that new information. Disadvantages includes the bioinformatic challenge of interpreting large volumes of data. And because of the large volume of data, there's a much higher chance of identifying secondary incidental findings that have ethical implications that we'll discuss. This modality, as you can imagine, is very expensive. Whole genome sequencing can be used for untargeted sequencing of coding and non-coding areas of the genome. The best utility for this methodology is for patients with heterogeneous or no specific clinical phenotype. It's also useful for undiagnosed patients that have already undergone targeted sequencing or whole exome sequencing, or for the discovery of new disease-associated loci in coding and non-coding areas of the genome. The advantages of this modality is its higher sensitivity with detecting single nucleotide variants, detecting insertion and deletion of small numbers of bases or indels, insertion and deletions of large numbers of bases, copy number variants in coding and non-coding regions. And because you're covering essentially the whole genome, there's more uniform coverage compared to whole exome sequencing. Disadvantage of this modality include difficulty in interpreting non-coding variants. We understand and know far fewer non-coding disease alleles than we do in coding areas. And like whole exome sequencing, this is also a very expensive modality, thereby limiting its accessibility. Targeted next-gen sequencing is rapidly expanding. This includes targeted sequencing of a set of genes that are associated with a specific phenotype. Many of you that are becoming familiar with commercially available panels of different sets of genes for FSGS recognize that this is the modality that is included. Next genome sequencing is useful for specific diseases or well-defined phenotypes and really good for phenotypes with low to moderate genetic heterogeneity. The advantages of this modality is that you're able to interrogate a group of genes related to a specific clinical condition all at the same time, so very efficient. It can be optimized to ensure sufficient coverage of variants in targeted regions, and it minimizes the chance of incidental findings that is very common with whole exome sequencing or whole genome sequencing. The disadvantage here is that you are testing a limited number of genes. There's a wide variability in the number of genes that different commercially available panels are providing. And so this reduces the sensitivity. Because we are rapidly learning about new mutations in disease, 10 years ago we knew about a handful of podocyte-specific mutations, and we're now up to more than 50. So there's a need for frequent updates and redesign to incorporate these new gene discoveries related to specific clinical conditions. The value of genetic testing can vary by disease, but the ability to confirm a diagnosis is a critical step forward in medicine. As the field of genetic testing has grown, it has become important to report results using developed criteria so that we don't overinterpret the available data and provide the clearest diagnosis possible. Because, as we know, obtaining a genetic diagnosis can lead to the initiation or change of treatment. Because a genetic diagnosis may lead to unintended consequences like discrimination, genetic testing should in all instances be preceded by patient agreement or informed consent, as well as appropriate genetic counseling. We have focused a lot of time on the utility of genetic testing. What's the argument against it when it's available? There are issues with interpretation. The presence of specific variants obviously varies with ethnicity. It is important, therefore, to compare the identified variants in a given patient against an ethnically matched data set. The frequency of a given variant in a database may attest more to the predominant ethnicity within the database than its potential pathogenicity. Variants for which pathogenicity is unknown can be termed unclassified, or as many of us are very used to seeing in these reports that we get back, variants of uncertain significance. Unclassified means that no attempt has yet been made to classify the variant with regard to its potential pathogenicity, whereas the term uncertain significance describes that the available evidence for classification is insufficient. Similarly, variants that seem to be pathogenic, but for which definite proof of pathogenicity is not available, are often denoted with the term likely pathogenic. Next-gen sequencing and whole exome sequencing is revolutionizing genetic diagnosis by facilitating analysis of known disease genes and discovery of previously unrecognized ones, and is a critical tool in our efforts to expand into personalized medicine. But the large amounts of variants identified may create several ethical dilemmas related to incidental findings of other disease-associated mutations, and therefore we need help in reporting these to families in an appropriate way. And then how do we manage the non-disclosure of socially relevant incidental findings and reports? This was a huge topic of discussion with certain findings in the adult world, like BRCA1 and BRCA2 associated with breast cancer. So back to our case, where we are having to make a decision with a child who has steroid-resistant nephrotic syndrome, fairly preserved creatinine clearance, but biopsy findings that are concerning for progressive disease. And the question is, what do you do as their nephrologist? And I would submit to you that there's no singular right answer here. Any of these options, given the nuances of a particular case, may be reasonable. In this child with a fairly preserved creatinine clearance, we may still want to try a calcineurin inhibitor, understanding the non-immunomodulatory effects of calcineurin inhibitors on the podocyte with synaptopodin stabilization. We understand that the response rate may be low, in particular with specific mutations. And so if you find that there's no response after 6 months, in our current KDIGO guidelines, we would really recommend that you consider pausing or stopping that therapy. In resource-limited areas, there may not be access to calcineurin inhibitors or genetic testing, and so RAS blockade may be your best option. If this particular child presented with advanced chronic kidney disease and an abnormal creatinine clearance, that may preclude the use of a calcineurin inhibitor. Genetic testing may certainly have its highest yield in children that are less than 1 at presentation, have a syndrome at presentation, or have a family history of steroid-resistant nephrotic syndrome. But we also now know from various cohort studies that mutations may be found in up to 30% of children with steroid-resistant nephrotic syndrome. The genetic testing here may guide treatment decisions and counseling for transplant. Obviously, this is all dependent on accessibility and cost to the family. And again, we strongly recommend having trained genetic counselors involved. So in summary, genetic screening in children with steroid-resistant nephrotic syndrome may mitigate exposure or excess exposure to immunosuppressive treatment. It may decrease disease misclassification from the limitation of histologic diagnoses, may aid in the prognostication for disease recurrence post-transplant. The role of trained genetic counselors is paramount both in the interpretation of results, but also in navigating the ethical challenges associated with reporting. And advancing technology is improving access, but there really should not be a one-size-fits-all approach to this. So thank you for your time to this presentation. I see that there are several questions that have come through, so I think we'll now move to responding to these questions.
Okay, thank you very much. That was a great presentation, and we'll dig into some questions here. Our first question is, are genotype-phenotype correlations ready for prime time?
I'll begin with this question and sort of highlighting the exciting landscape that's really developing around this. I think that as we are moving more and more into this area of precision medicine, and we see more and more studies that are being developed with the systems biology approach. I'll just take, for example, the Nephrotic Syndrome Study Network, or Neptune study, that is really working hard to tightly phenotype and genotype patients with nephrotic syndrome, but in addition to that, really looking at the entire system biology, so correlating that with proteomics and metabolomics. I think that we're getting closer and closer to being able to rely less on histologic classifications, which at times have led us astray, and able to really understand how to interpret the genetic data that we're getting with individuals and correlating that with more distinguishable phenotypes within nephrotic syndrome.
Yeah, and I think in the adult population, I think, as I mentioned, the genetic mutations for adults with FSGS has a much lower incidence compared to the pediatrics, and really the main genotype-phenotype correlations that we see that should be amenable to genetic testing will probably be a patient with syndromic features. But even then, these are very rare conditions, and I think for the adult population with FSGS, this correlation is probably not yet ready for prime time.
Okay, thank you for that. Next question is, what about genetic testing in sporadic forms?
Well, maybe I'll take that question. And as I mentioned, I think for the adult population with FSGS, there is a paucity of large studies. And in one of the biggest one that we had from the Toronto Glomerular Nephritis Registry, we only detect genetic FSGS in about 8% of the population. And so it's a very low genetic diagnostic rate in sporadic diseases in the adult population, and unless the cost of genetic testing comes down, I think it's not cost effective to screen all patients without a familial disease with genetic testing, because the cost will be phenomenal. In addition, genetic testing is also not readily available in many parts of the world. Genetic counseling is not available in many parts of the world. So therefore, I think a more targeted clinical approach, like perhaps we should only consider genetic testing when there is a failure to respond to immunosuppression treatment, because that actually increases the diagnostic yield, and make perhaps genetic testing a little bit more cost effective compared to just widespread screening in sporadic cases.
And likewise, in children with steroid-resistant nephrotic syndrome, there is wide variability in the prevalence of these podocyte-specific mutations. The prevalence is likely closer to 10% in children, and certainly if you look at the younger side of that spectrum, so children under the age of 1, your yield is going to be much higher. I do think that based upon the cost of these tests and the accessibility of these tests, that we are not in a position yet where we can widely recommend genetic testing in sporadic forms. But certainly from region to region and thinking about your resources, there are populations where this makes sense. It makes sense in those young children. It makes sense in a child who has syndromic features. It makes sense in a child who has a family history of steroid-resistant nephrotic syndrome. But outside of that, I think that there definitely needs to be informed discussion with the patient family and truly understand what your goals are with this testing.
Okay, great. Thank you. Let's see. We'll take this one next. Could you further explain the spectrum of disease genes and pathogenic variants in adult versus pediatric NS?
We certainly see patterns in pediatrics in regards to prevalence of specific mutations. Again, I highlight understanding and paying attention to the child that's in front of you. If this is a child under the age of 1, then mutations related to nephrin are going to be highly prevalent. We start to see podocyte-mediated diseases, certainly in children under the age of 2. There are other podocyte-specific mutations that we see in pediatrics that are less common and become more common as you move into older adolescence and early adulthood, like TRPC6 and alpha-actinin 4, WT1 associated mutations. So the world of our known podocyte mutations is rapidly expanding. I think that we're going to need the assistance and help of these large registries like POTANET, like Neptune, like CureGN, and others to help us understand what the spectrum truly looks like.
Yeah, but unfortunately, I think in adults, the number of studies and the lack of large studies sort of made the adult population kind of lag behind the pediatric population. We have less number of genetic pathogenic variants as compared to the pediatric population. And I think the other clear difference between the pediatric and adult population is kind of the mode of inheritance of this monogenic genetic variants. So for example, so most of the pediatric nephrotic syndrome is inherited in an autosomal recessive kind of pattern, whereas in adults we tend to see a more autosomal dominant. So I think that's one of the key differences between the adult and the pediatric population. But I think I agree that I think more studies are needed to help us to map out the spectrum of diseases that's associated with the genetic variant.
Okay, great. Thank you. And as a reminder to our audience, questions that we don't have time for, we'll pass along to our presenters for individual follow-up. Next question is, what are the benefits of initial gene panel testing versus screening protocols?
Well, so if we do individual gene testing, it's definitely going to be very much cheaper. And because it's very targeted, the quality of the sequencing is also much better compared to screening protocols. And of course, the disadvantage of using a targeted approach is that we may not be able to pick up new gene mutations, and we may not be none the wiser after the genetic testing. At least that's certainly the case for the adult population.
Mm-hmm. I really don't have anything to add to what Adrian said for that one, so maybe we'll let that one stand. Okay, I'll take the next one.
Okay, here we go. What are the roles of WES and WGS in testing?
Mm-hmm. So whole exome sequencing, whole genome sequencing, these modalities compared to our targeted sequencing panels really have utility in those patients where the phenotype is not clear. Yeah, my best example in pediatrics is in our neonatal unit, where we have a child before us that has multiple abnormalities, some dysmorphic changes, renal involvement, maybe other organ involvement, so no clear phenotype. And so because whole exome sequencing and whole genome sequencing has such high sensitivity for picking up these loci, there's a greater chance of finding these variants of significance. With targeted sequencing, you again are going after a finite number of genes, and so you really have to have a good sense of the phenotype you're looking for. In our case here, we're focused on steroid-resistant nephrotic syndrome and/or FSGS. And so with that, you know, there are different panels that are out there that have genes that are specific to that. And it's important to look at what those panels are interrogating. They're not all comprehensive, but some may have genes that are more relevant for the patient that you have before you. They may have genes that have more autosomal dominant hereditary pattern. And so if you have a family history in front of you, you may be able to think about which genes are more relevant to that patient and help you pick the panel that works best for you. But again, whole exome sequencing, whole genome sequencing, much greater sensitivity, but very expensive modality. So really good for gene discovery when you really don't have a tightly defined phenotype.
Okay, great. On behalf of the audience, I want to thank both of you for your great presentations and deft handling of the questions. Thank you very much.
Thank you. Thank you.
Thank you.
A reminder to keep your eye out via email and social media for details on episode 3 of our series. At this time, we will end the webinar, and you may now disconnect.